So Kristin and I were part of a panel at ASBH. Since, who was it again? Cleveland Clinic was the other group that presented their ethics champion model, but we took their slides off, obviously, and we're just going to do our own models. So our objectives were just to kind of understand the strengths and weaknesses of the different programs, identify key challenges that we had in developing and maintaining these programs, and implement or improve our programs. So I am Karen Jones, and I am the clinical nurse ethicist at Children's Hospital right now. I come as a NICU nurse of 36 years before I did this, so I guess I'm now in my 37th year as a nurse. And so I've had this job for just a little over a year. The program started in 2004 with a pediatric ICU nurse, Jenny McCurdy, and she just recognized in the PICU in 2004 that there was some ethical challenges that the bedside nurses were having, and so she just sort of developed this small little committee. Under her, it grew to be 30 nurses from 15 different settings. Most of those were inpatient settings. I was one of the original 30 nurses, so I've been doing the actual Liaison program since 2004. At that time, we met quarterly, and it was really educational. We'd have a case review and talk about a case from different settings, and just kind of get together as, you know, a small group of nurses. She was able to build her committee work into a part-time clinical ethicist position, which I think she's probably one of the first in the country. When she left, I think in 2012, Heather took over, and through Heather's work with the ethics committee and then becoming a co-chair on the ethics committee, she built the clinical nurse ethicist into a full-time position. She grew the program to be 80, well, she grew it to be 60 interdisciplinary members from 35 settings. Her biggest accomplishment in the Liaison program was really making it multidisciplinary. She reached out to the social workers and the chaplains and the advanced practice providers and all the different multidisciplinary clinics, and really grew from that perspective. So she left, like I said, about a year and a half ago to be my boss, and I took over as the full-time clinical nurse ethicist and have grown the members to be 80 different multidisciplinary individuals. We added in the patient reps, which very interestingly, they have a great deal of moral distress in their job, even though they're not clinical. They take patient complaints, and it's very stressful. I have the child life, I have research, so it's really become not just the bedside team that has become members of the liaisons. So the liaisons are, it's a really informal, they're either self-selected or they're nominated by their manager, or it comes to them, they attend a moral distress rounds and they think, wow, that seems like a great, you know, thing, how do I get involved? It really is not very formal. Once they are selected, I do some education, which I'll talk about in a bit, but we really want anybody who has a passion for ethics to join. So I don't have a specific number for every setting. I'd like to have at least 2 in every setting, because as we all know, it helps to work with a buddy. Some settings have 8. The NICU has 8 or 9. The PICU has 7. CCBD has 7 or 8. The bigger units have a great deal of liaisons, and it's very helpful because they work all the different shifts, weekends, nights, days, and that can really help with kind of identifying clinical ethics issues and moral distress. So I do an initial 2-hour onboarding. Before COVID, I used to bring everybody together in a room, and I used to do about 3 of them a year, which was great because we could talk about, you know, different settings and kind of, you know, learn from each other. But with the onset of COVID, I really do it, I've pared it down to be 1 hour, and I usually just do it individually, virtually. Right now, they're allowing staff to do some things that aren't direct patient care, but not very much. So I really couldn't justify a 2-hour onboarding. So I've really minimized it back down to it's kind of a 1 hour. And it's basically just Ethics 101. Jackie, I don't know if you guys have seen this, but Jackie did an amazing Ethics 101 handout that we were going to use for our our conference last year, and since she did all that work, I use it because it's got definitions and it's got theories, and it's really a nice handout to kind of jump off our education. So I use that. We talk about some of the cases that sort of have been, you know, really important in Children's Hospital. We talk about shared decision making, you know, basically pediatric ethics. I don't really get into much adult ethics. We do talk about adolescent decision making, which sort of starts to get onto the edges of adult, but it's pretty pediatric focused. The other education we do is that instead of having monthly meetings, which were really challenging for staff to get to, we could never figure out a time that worked for everybody, whether it's noon or 7:30 in the morning. Somebody was always in overtime or couldn't get away from the bedside. So Heather came up with this great idea that we would round at the settings, and I have continued to do that. And it's amazing. They just figure out, you know, on a monthly basis, everybody's going to work Thursday, you know, the second Thursday of the month, and I go to the units. And we can get a lot more specific for that unit in either education or thinking about some of the patients that they have. So we'll run a list, we'll talk about the different long-term patients that may be causing angst, or we, you know, think about what kind of education we can do for that particular unit. We do have 4-hour retreats, not right now, of course, but prior to COVID, we were having quarterly 4-hour retreats, and we will start that back up. Hopefully we can start that back up in June when Children's allows us to have not just in person, but allows us to have education hours again. They are invited to ethics committees at least quarterly, more often if we have a topic that is really of interest to them. Of course, they get to come to the annual ethics conference free of charge. So that's something that the ethics committee really does to support the liaisons. The liaisons are really an offshoot of our ethics committee, and we get a great deal of support from the ethics committee. And we have always sent them, you know, the information from the grand rounds, but this past, 9 months with all of the virtual online across the country virtual education, it's been great because I have just constantly forwarded them. And I have a lot of liaisons who, you know, they just sort of pick and choose, but they have, they've watched a great deal of those. So really the role of the liaison for me is really getting the resources of the ethics committee to the bedside. The intent was never to develop an ethics consultant. Some of our liaisons are consultants. I was a consultant as a liaison. Charlotte is one. Grant was one. But it's really not. That's not the goal of the liaison. It's really to be at the bedside, be in the units, be in whatever department they're in, and to be thinking about situations as they hear them, and is this an ethical situation, and what are my resources? How can I either handle this individually, or how can I reach out to Karen and then the other ethics faculty? One of their biggest jobs is recognition of moral distress. It's been really interesting to watch as we've educated the liaisons on what moral distress is and what moral distress rounds are, how many moral distress rounds we've been doing. I probably do 6, sometimes 8 a month. And I'm doing them with units and departments that I never thought I'd be doing them with. Like I said, the patient reps, we probably do 1 a quarter for the patient reps. They just have a really challenging job, and it's been very helpful for them. So ultimately, we want to improve the ethical climate through the moral distress rounds, through having resources of the ethics committee. Ethics consults often are suggested by our ethics liaisons. They either contact one of us. They've been known to put the order in, or they're just sort of, you know, nudging the providers to call for an ethics consult. Let's see, I guess that's all of me. Okay, Kristin.
So at university, our program is quite young compared to Karen's. So our program started in 2019, January of 2019, and actually didn't continue fully in 2020, given all the challenges that we had with the pandemic and people being in and out of the hospital. But we've only had about a 2-year program. And our program was developed to address the challenge of delayed ethics consults. So at university, we recognized that there was often a delay in terms of receiving an ethics consult. We were called really late in a patient's stay, often when there was already a lot of frustration and a lot of distress about the situation. We recognized that had we been called earlier, we probably could have helped much more. It was much later than we wanted to start having conversations about values and hearing the different voices. And so our goal was really to try to address this delayed ethics consult. We also recognized that across the hospital, different units and different specialties have different needs. And it seemed unrealistic to expect people who didn't have training in ethics consultation to be able to identify the correct timing of calling ethics. And so our plan was to create this ethics ambassador program to embed individuals in their unique unit and their unique specialty to serve as a resource for their colleagues. And we chose the name ambassador intentionally to show this, that these people are a representative of the ethics program, but really embedded in their unit, in their specialty, and really working with those people that they do their clinical job alongside. Karen, I think you can hit it. I think you can just hit them all.
Whoops.
Thanks. So our program is interprofessional. Again, we recognize that there are different needs across the hospital and different units and different specialties. Our first year, we had nurses, we had a float nurse, we had charge nurses, we had night nurses, we had a social worker, we had a physical therapist, and we had a research assistant. So quite a variety of ethics ambassadors. They were self-nominated. So similar to Karen, these are people who have an interest in ethics, not necessarily with specific ethics training, but they applied to our program and were selected through an interview process. And once they were selected, they participated in quarterly training. So we also did a quarterly training speaking about the nuts and bolts of ethics, foundational ethics principles, those types of things, like Ethics 101. They participate in our consult meetings. We have meetings every Monday in which we discuss the consults of the week. So they participate in that to get some skills about ethics consultation. And then in addition to that, we asked all of our ethics ambassadors to develop a project. And the hope was that these projects would be authentic and intrinsic to the unit that the ambassador came from, really aimed at addressing a need that they identified there. So many of them started with a broad needs assessment. All of the projects were mentored by ethics leadership. And then at the end of the year, they presented their projects at the ethics committee. We also invited hospital leadership. They didn't come, but we invited them to come to hear about the projects that our ambassadors were doing, and to really stay appraised of the things that we were trying to accomplish through our ethics program. You can go on, Karen. Thank you. So our program objectives are here. We'll talk later on about whether we were actually able to accomplish these things, but we were really hoping to increase our ethics presence. Again, we really just wanted to extend our reach across the hospital and hope that by using these embedded ambassadors that we would be able to do so. We actually even made little pins for the ambassadors to wear on their lanyards or their badge, just again to keep ethics on the forefront of people's minds when they encountered a difficult situation. We wanted to engage in earlier consultation, earlier recognition of ethical challenges and moral distress. We wanted to increase staff knowledge about ethics consults. Many of our ethics ambassador projects included an educational component, and we thought that by using the ambassadors to do that education, people would be much more inclined to participate if it was one of their colleagues as opposed to just some ethics person from somewhere that they don't know. So really engaging these people as true embedded resources for their colleagues. We, unlike Karen, we actually do see these as this as a possible pipeline for ethics consultants. Our ethics consultant pool is relatively small at university, and part of that is because there's not a lot of funding for this, and so we really wanted to to be able to start developing a pipeline, we figured that after a year of engaging in this work and doing the training and doing the project, that people would be poised to be able to step into a consultant role. I will make the point that our program, they're all volunteers. So we have no funding for the program at all. We have no funding for the ambassadors, and we have no funding for the program management. So these ambassadors have really just stepped into this role because they're interested and this is something they want to do. We have tried really hard to engage their work in meaningful ways so that it helps their career advancement as well. For example, our nurses were able to use their ambassador program for their leveling up, so their career development as well. All of the ambassadors had their supervisor's permission. The supervisors received a letter stating that the individual was going to be an ambassador. And so hopefully this helped with their career advancement, helped create some leadership opportunity for them. And then finally, our big pie in the sky goal was to help create an ethical culture and climate at university. Go on. So metrics and outcomes. Let's see, Karen. Karen, you're muted.
Computer challenges this morning. So similar to Kristin, our liaisons usually have a unit-specific project. It is very specific to whatever is happening in that particular unit, and so they're a variety for sure. The NICU did a moral distress survey, and they surveyed, I think it was about 4 years ago. And then they implemented some interventions, and then they resurveyed. And they actually were able to present this poster at the National Nursing Ethics Conference. So basically what they learned through their moral distress survey was that education was a huge component, or miseducation, misunderstanding of what ethics is. And so they've really developed a lot of tools for the bedside nurse. They have a website, a SharePoint, that one of the liaisons keeps up to date with new podcasts and articles that I send her, and they do some discussions. For example, we're pushing the limits of viability in the NICU, or 23 weeks is now kind of common, and we're looking towards 22 weeks. And so this is something that is distressing to the staff, and so we sort of we do lunch and learns, and then we put things on the website to kind of help staff if they're just middle of the night and they're kind of thinking, oh, I wonder if there's an ethics article out there. They can kind of go to this site. The PICU did something similar. They did a ethical climate survey, and then they took what information they were given and they did interventions. For the PICU, it was really rounding. The ethics liaisons rounded regularly on especially the hot kind of button patients, the ones that were really intense, to just kind of talk to them and see whether or not they had, just regular distress, or did they have moral distress about what was happening at the bedside. Our child life is doing ethics education. Our 8th and 9th floor are embracing their new grads. They recognize that when you come to a medical floor, or the 9th floor, which has all our chronic trach vent patients, that there can be some real ethical dilemmas with these kids, not necessarily that bubble up to a consult, but can be really morally distressing. So they really hit the new grads hard on that unit. Emergency department, again, they're doing a survey right now, and then they're planning for interventions. And the oncology team has really started to implement moral distress rounds for their bone marrow transplant, or not bone marrow, yeah, bone marrow, sorry. Transplant patients. There's some incongruent communication between inpatient and outpatient, and it's so important that everybody's on the same page when these kids come up for their transplant, that they found that doing some team meetings and embedding some moral distress rounds in there has been very helpful for them. So that's just an example. I mean, there's probably 20 projects that are happening in different stages at Children's. One of the things that Heather was involved in was a multi-center survey in which they they surveyed the liaisons. So this is not all the hospital staff, but this is just the liaisons and whether or not they feel like what they are doing is making a difference. And as you can see, they definitely felt like that there was an improved sense of questioning and learning and to ethical problems. They felt like their moral distress was diminished by the fact that they had access to ethical supports. Certainly, we need to do more work because we need this to be across the actual organization, but it was good to see that at least the work of the liaisons was helping. And one final thing that I don't have a slide for because it just happened was Children's was up for their 4th magnet designation. And for those of you who don't know what magnet is, it's a designation that the American Nurses Association puts out. And it's a huge deal for hospitals to be magnet recognized. And we were up for our 4th, which I guess is very challenging to get. So they came in August. The surveyors were here for a week and they met with the ethics committee and the ethics liaisons. And the surveyor was immediately impressed in that 1 hour, and she told us how impressed she was. But it wasn't until they sent the document out that we really heard how absolutely impressed they were with the ethics liaisons and the ethics committee. And it's the support of the ethics committee that the ethics liaisons have such a strong voice in the hospital. And so it was great for the work that has been previously done by Brian, Jackie, Dan, Heather, and now Curtis and I. But what it really helps me with is for moving ahead, being able to speak to the unit managers where I struggle to be able to get liaisons and say, hey, look, this has been recognized as an exemplar and please help me, get some liaisons for your unit or your department or whatever it is. So I'm looking forward, to being able to take it and go down to Colorado Springs and go out to the North Campus and South Campus and really just keep trying to grow the program. Because magnet not only, yes, it affects the nurses, but it affects the hospital. People really, really, really like to work at a magnet hospital. The turnout is lower, the patient outcomes are supposedly better because you have such engaged nurses. So it was a big deal, and I'm so proud of our ethics committee. Okay, Kristin.
All right, so our metrics. We all know how hard it is to measure quality outcomes of ethics work. And so similarly, we have struggled to try to measure the outcomes of our Ethics Ambassador program. I'm going to show you the things that we have started to look at. So this first slide, I know it's probably hard to read, but it's a survey that we gave to our ethics ambassadors pre-program, and then again, same questions post-program. There were a total of 15 questions. This is just a representation. But we were trying to measure their perceived preparation to engage in the activities that we wanted them to do as an ethics ambassador. So recognizing moral distress, engaging in ethical conversations, recognizing ethical values, talking to people in different specialties, all of those things. Green was pre and blue was post. And so you can see in these questions, actually, in fact, in the entire survey, that our ambassadors demonstrated or self-reported perceived increased feeling of preparation and ability to engage in these activities. And that's great, but probably not much of a surprise to us because these are the things that we taught them during their quarterly trainings and during their time as an ethics ambassador. And so, Karen, next slide. Then we tried to measure how the ambassadors impacted the stakeholders. So the stakeholders being anyone that they engaged or interacted with as an ethics ambassador. So anyone in their unit, anyone in their specialty, anyone in their circle of influence, essentially. So we asked our ambassadors to each send out 10 surveys. These were electronic anonymous surveys. Asked them to send 10 surveys to people that they engaged with as an ethics ambassador, and wanted to see what that looked like. So again, this is just a representation of those answers, but we asked the stakeholders, how did interaction with your ambassador help your ability to communicate concerns, recognize ethical problems, recognize moral distress, all of those things, again, that we expected our ethics ambassadors to be doing. And so on this slide, the orange, the dark orange is very much, and then the mid orange is somewhat. So you can see it definitely trends towards positive, that the stakeholders in interactions with the ambassadors did improve their abilities to do these things. And so now I feel like we're demonstrating both that we've impacted the ambassadors, and then by extension, each ambassador has had some impact with 10 people that they interacted with. So we're starting to show a little bit of that ripple effect of the ambassadors program. And Karen, the next one. So as I mentioned, all of our ambassadors did a project, and I'm going to highlight 2 of them here for you. They were all wonderful, and I think really interesting to see the variety of the projects. They were completely designed and developed by the ambassadors themselves, so truly did address a need that the ambassadors identified in their unit. So the first project was our research assistant, and he did work in the ICU. He recognized that in the medical ICU that there were often delays in identifying and documenting medical decision makers. So he started with just an educational piece about the policy, hospital policy, Colorado law about decision making. He then worked closely with our palliative care champions at University Hospital, and together they created an EPIC dashboard that shows which of the ICU patients have a medical decision maker. It shows how it's documented, and it shows when it occurred. So they can measure in real time medical decision making in the ICU. They've been following that monthly and have been able to demonstrate increased percentage of documented MDPOA and proxy in the ICU. And so this is a pretty large impact in our medical ICU care of our patients. The second one was our social worker, and kind of along similar lines, actually. He recognized that there wasn't a standardized process for social workers in engaging in finding decision makers. So often when we have a patient who doesn't have advanced directives, hasn't identified a decision maker, we turn to our social workers to help recognize interested parties and help those conversations to truly identify a proxy. So he created a process by which the social workers look in the chart and start to outreach to identify interested parties. He created scripting for social workers to use in having conversations with families or other interested parties so that they were communicating the things they needed to be communicating. And then he created a training module for all the social workers. So he did 3 different trainings to capture all the social workers currently at university. And what he created has now become a required training module for all social workers who are newly hired into university. So I highlight these 2 projects because I think they really do demonstrate how standard work has been created out of the projects of the ethics ambassadors, and what they've developed has really just become a normal process and procedure for what we're doing at University Hospital. So again, I think that bigger impact of the work that our ambassadors have been doing. And the next slide, Karen. Oh yes. So then some of the other outcomes we tried to look at. So from an educational standpoint, we now have regular educational and case discussion sessions in certain units, the units with ambassadors. Moral distress rounds is happening in the rehab therapies department, and we have engaged a lot of interest there in working in the moral distress arena. We looked at our consult volume in those units that have an ambassador, and to be honest, I have no idea how to interpret this. I think you have to look at volume and then you don't know what to do with it. So in the social work department, social work case management, our consults doubled when we got an ambassador. So 10 consults came in the year before, 22 in the year that we had an ambassador. That said, in the physical therapy, OT, speech department, our consults cut in half during the same time period. So who knows what that means? I mean, it can obviously just be normal variation. Could be that our social workers are really able to recognize, could be that our physical therapist did great education and now they can handle it on their own. Who knows? But interesting trends to note. Hard to say if this will be, continued trends or if this is just a normal variation. We also spent a lot of time looking at the time to consultation, because again, as I mentioned at the beginning, that's what really led to the development of the to show an impact in time to consultation. We hoped that by having ambassadors that we would be able to show earlier ethics consultation. Unfortunately, that was not the case either. So again, looking at those units that had an ambassador, we pre-ambassador had, you can see on the side there, the bars. So the length of stay is the entire bar. So average length of stay of 15.5 days. I threw out the crazy outliers, greater than 30 days. But length of stay average of 15.5 days. And before ambassadors, we were called on average day 5.3. So about a third of the way into the patient's hospital stay, ethics was called. We wanted that to improve. Unfortunately, in 2019, a similar length of stay, 14.1 days. In those units with an ambassador, we were called on day 8.6. So over halfway into their length of stay, the ethics consult was received. So again, hard to interpret. This is just 1 year of data, but it shows the things that we're trying to start measuring as the result of our program. And I would value any feedback or any other ideas of ways to continue to measure the impact that we're having.
Okay, key challenges. So for me, the couple of the things that I'm really focusing on for the next year is to work on the different level of education and experience that my liaisons have. I have liaisons who've been liaisons since the beginning with me, or for at least 10 years. And so they have a great deal of education, having been exposed to ethics education for, the 10 years. And then I have, brand new liaisons who I do an onboarding with and who I meet with, on a routine basis, but it's still, there's still this bell curve of knowledge. And so one thing that COVID has done for us is it has allowed this virtual conversation and training, and Children's was dead set against working from home for anybody, but especially the bedside nurses before this. And now there's some movement, and I think the movement is probably going to stay. So I'm looking forward to the fact that maybe I can do some education with staff without having to bring them all into the same room, because that's what gets so challenging when I'm trying to provide education to bedside staff, because none of them work the same shift, the same day, or the same, anything. And so if they're willing, and ethics liaisons they're just passionate. If they're willing to do it on their day off and still get paid for it, which Children's will do, I have some hope that I can use this virtual platform. And I still want to do the retreats, but I can do some maybe 1 hour or 2 hour sort of ongoing education. But that has definitely been a problem. It was a problem for Heather in her days of being the clinical nurse ethicist. So monthly rounding, I try and round with all the groups. It's very time consuming, and it's not really equitable because there's a lot of units in which they can't pull it together and have me round with them because of either their workflow, or they're not all working on the same days. And so that's a little, it's a little unfair. And so I'm working on trying to figure out, and again, maybe this virtual platform is the way to manage that. It doesn't always have to be in person on their unit. The biggest thing for me is I really want to get impact data on moral distress rounds. Like I said, we're doing a lot of them. It's interesting when you compare the moral distress to the ethics consult cases, and REDCap is really going to help us with this, but oftentimes either the moral distress comes first and then the consult, or vice versa. We have a consult and then the team recognizes that yes, that consult was great, but we're still having moral distress, and so we have moral distress rounds afterwards. So I really need to narrow this down as to like which comes first, which is best. How do we measure whether or not people feel better when they leave moral distress rounds? We can assume because they call back for more, and oftentimes it's a different group. They've heard through the grapevine that this is going to be helpful. I mean, I have a lot of anecdotal information, but I don't have anything that actually says, yes, this is helpful, this is valuable, let's keep doing it. So that's something that maybe the researchers can help with that. And maybe once we do have our red cap, we might find some trends and hopefully can publish on this. Kristin, I think you're next.
So
Oops,
our
sorry.
Oh, you're fine. So our challenges, as I mentioned before, we have no money for this. So our program is completely unfunded right now. Our ambassadors are all volunteers. And so it's been a little bit difficult to get the program running, has made it difficult to make it bigger, and certainly does limit what our volunteer ambassadors are able to do. We've tried to be really intentional about aligning the work that we're doing with the mission of the hospital and really trying to show that what we're doing helps the broader community. I have sent a couple little emails we reached out to the CMO, the CQO, the CNO with just updates about the program, updates about the work that our ambassadors have been doing. Like I said, we invited them to the ambassadors presentation to try to demonstrate that work, but haven't had, I don't think, a lot of success yet in really being on their radar broadly like we want to. But hopefully with continued work, we're going to move a little bit into the moral distress arena, and that's a big focus of the hospital right now. So hopefully that will help us become a little bit more visible in the work that we're doing. And I think the other challenge that we have, that everybody has, is truly measuring the impact of the work that we're doing in this arena. I think that's all we had. Yes.